Good morning. I'm Erica Schorr, an associate professor in the School of Nursing and co-chair of Research Day. Welcome to the 2021 Nursing Research Day. The theme this year is Care and Caregiving in a Complex World. As many of you know, we were unable to hold Research Day 2020 due to COVID-19. Today, through our first virtual Research Day, you will have an opportunity to learn about a broad range of research and evidence-based clinical projects and their implications for practice, policy, and future research. Research Day also provides a great opportunity for you to network with faculty, students, alumni and community, clinical and corporate partners, and you're encouraged to reach out to participants during and following this virtual event. If you have questions, we encourage you to visit the Nursing Research Day Google website that includes contact emails of people who will assist you. We value your feedback for planning next year's Research Day. An online evaluation form will be emailed to you following Research Day. Please keep an eye out for it. For those of you interested in claiming ANCC contact hours for your participation in the 2021 Nursing Research Day Conference, you will need to be in attendance for our keynote and complete the online evaluation and continuing education verification using the link provided on the PDF handout that was emailed to you before the start of the conference. The link can also be found on the ANCC information section of the Google site. We will also be emailing the link to all attendees on Monday, April 19th. Please note, this evaluation is open to all attendees, and we encourage everyone to complete the evaluation as your feedback is appreciated and helps with the planning of each year's Research Day. The online evaluation and continuing education verification will remain open until Monday, May 3rd. Please make sure to have completed this in order to receive your continuing education certificate. Certificates will start being issued after May 3rd and will be emailed to you by May 31st. If you have any questions regarding the process for claiming ANCC contact hours, please email Taylor Gillard at soncne.umn.edu. Please allow 1 to 2 business days for a response. Now, it is my pleasure to introduce you to the Dean of the School of Nursing and the University of Minnesota, Connie White Delaney. Dean Delaney is a national and international scholar in informatics who is leading a number of big data science initiatives.
Welcome to the 2021 Nursing Research Day here at the University of Minnesota. Innovation is a hallmark of research and scholarship conducted by the school and in collaboration with community, clinical, and corporate partners. Today, you will learn about cutting-edge research and systems innovations that are improving the health of individuals, families, and communities. We are transforming healthcare. I invite you to share the excitement of this day and celebrate the science of nursing. This has been another landmark year for the School of Nursing and its advancement of nursing and nursing science. Here are a few highlights. The University of Minnesota is currently ranked 12th in NIH funding for nursing schools in the nation, first in the Big Ten. Today, you will hear presentations related to many of these innovative research projects that are improving the health of individuals, families, and communities, as well as transforming our healthcare delivery. Last month, our Doctorate of Nursing Practice program rose to 18th ranking in the U.S. News and World Report, and our nurse midwifery and nursing informatics specialties remain second in the country. The school's commitment to planetary health and addressing the relationship between human health, the environment, and the health of the planet is robust, including our partnership with the Planetary Health Alliance at Harvard University. Nursing's system thinking is essential if we are to create the necessary healing opportunities for individuals and our planet. And our school is leading these efforts under the direction of Teddy Potter. Teddy was the first director of planetary health established by a school of nursing in the country. The university was recently awarded a $4.48 million contract from USAID to support health sciences higher education advancements in Afghanistan. This program expands upon work done by a team led by our Director of Global Health, Carolyn Porta, who has done a remarkable job building relationships between our school and leading institutions around the world. At the national level, we celebrated the appointment of Dr. Shannon Zank as the Director of NIH's National Institute of Nursing Research. And in June, we will host the 9th Annual Nursing Knowledge Big Data Science Conference. We are thrilled to have Molly McCarthy, Microsoft's National Director, U.S. Health Provider and Plans, and former Chief Nursing Officer as our keynote speaker. We will continue our work to ensure that nursing data are captured and available in shareable, comparable formats for clinicians, administrators, you as researchers, policymakers, and others to improve health outcomes. And although we haven't been able to meet in person for more than a year, this past year has brought us together with health systems, businesses, and the community in ways never thought possible. And I am excited for these relationships to flourish even more in the days to come. It takes a village to host an event like Research Day, and on behalf of the University of Minnesota School of Nursing, we would like to share our deepest gratitude for our supporters. These supporters include the Minnesota Organization of Registered Nurses, Sigma Theta Tau International, Zeta Chapter, Winona State University, Department of Nursing, and the Mayo Clinic. And our Research Day and partners include Abbott Northwestern Hospital, CentraCare, Children's Minnesota, Gillette Children's Specialty Healthcare, mHealth Fairview, Minneapolis Veterans Affairs Healthcare System, Park Nicollet Methodist Hospital, Regents Hospital, Sigma Theta Tau International, Kappa Phi Chapter, St. Cloud State University, and the University of Minnesota School of Nursing and the School of Nursing Foundation. Representatives from these organizations have also served as community advisors for today's program. You'll find their names on our website homepage. We also extend our gratitude to our community partner advisors and Nursing Research Day volunteers. They are pictured on the screen. We are thrilled you are able to join us for this remarkable day, celebrating innovative research and evidence-based practice projects that are addressing health issues across the lifespan and in local, state, national, and global context. And finally, and most importantly, we acknowledge that the School of Nursing and the Twin City campus of the University of Minnesota is built on the traditional homelands of the Dakota people. We recognize the long-standing relationship between the land and the Dakota people, the traditional stewards of this land. We also acknowledge the violence of colonialism and ongoing racism toward Indigenous people. We are growing in our realization that the healthcare system meant to protect and heal people has supported structures of racism causing ongoing trauma and health inequities. As part of the process to heal the land and the community, we reflect on these questions. What are our obligations to the people who first inhabited this land? How do we figure out what our responsibilities are to this land? How can we be good guests here? How can we support existing local struggles? How can we work together to promote the School of Nursing's vision to ensure optimal health and well-being for all people and the planet? By living here, working here, and using the resources of this place and in this moment, we now participate in this experience. I now welcome back Dr. Erica Schorr to introduce our keynote speaker.
Thank you, Dean Delaney. Our keynote speaker, Dr. Dionne Odom, is this year's recipient of the Barbara O'Grady Lectureship. This lectureship honors the legacy of Barbara O'Grady, who was an influential public health leader and generous supporter and alum of the University of Minnesota School of Nursing. It is now my pleasure to introduce Dr. J. Nicholas Dionne Odom. Dr. Dionne Odom is an assistant professor in the School of Nursing at the University of Alabama at Birmingham and co-director of Caregiver and Bereavement Support Services at the UAB Center for Palliative and Support Care. Dr. Dionne Odom's program of research focuses on the development and clinical trials testing of early palliative care, lay navigator-led interventions to enhance the coping and decision-making skills of family caregivers of persons with serious illness, particularly advanced cancer and heart failure. Dr. Dionne Odom is an active researcher. He receives research funding from the National Institute of Nursing Research, the National Cancer Institute, the National Palliative Care Research Center, the Gordon and Betty Moore Foundation, and the Cambia Health Foundation. He is the 2020 recipient of the Friends of the National Institute of Nursing Research Protégé Award and was recently named one of 10 inaugural Betty Irene Moore Fellows, a national program to develop the next generation of nurse leaders and innovators. We ask that audience members use the Q&A function within the Zoom webinar. You can post your questions at any time during the presentation. Dr. Diane Treat-Jacobson will moderate the discussion following Dr. Dionne Odom's presentation. Now, please join me in welcoming Dr. Dionne Odom.
Well, good morning out there, everyone, and thank you so much for inviting me to speak today. It's a real honor to get to speak at you all's Research Day at the University of Minnesota, and especially to talk about one of, well, my most favorite topics. You know, for a lot of you listening to this out there, you might actually be caring for someone with a serious illness, and so the things that I'm going to talk about today might be actually really personal to you. And you know, for most of us listening to this, I imagine that we get paid to take care of patients and their families, and yet many of you, you know, out there right now might go home and be doing the very same thing for some of your own family out there. And this is all to say that caring for someone with a serious illness, it's one of those real quintessential human experiences, and it's one that it's going to be personal to all of us at some point in our lives, whether it's something that we're doing right now or something that we're doing in the future, or whether it's something that we're going to be doing for someone, or whether it's something that someone will be doing for us. My program of research focuses on developing and testing early palliative care interventions to support family caregivers of patients with serious illness. I think everyone should have a vision of what they do, something that gets them revved up every day. And for me, that vision is really to see that families of those with serious illness, particularly those from historically marginalized backgrounds — I do live in Alabama here in the Deep South — that those folks they're seen, they're recognized, they're supported, they're trained, and if at all possible, that they actually thrive. So this morning, I'm going to talk about three things. First, I want to describe my first-person perspective on the urgency of finding ways to support family caregivers. Second, how I think palliative care, through the lens of some of the work I've been able to do, can address this need. Finally, to those of you out there listening to this who are early in your research career, I'd like to highlight a few affordances that really helped propel me to get to where I'm at. So to start, I really want to ask the question, why should we care about family caregivers in serious illness? And honestly, this question might be better phrased: why does Nick think that family caregivers are a priority? And that's because my story starts here. I'd like to invite you into this room for a second. This is an intensive care unit. I was a nurse in these kinds of spaces for 10 years. This is a pretty typical scene. This is morning rounds. Maybe it's about 7:15 during shift change. You know, that would have been me right there. I was the night nurse. who really couldn't wait to pass the baton to the day nurse. In my head, though, is, you kind of look across this room, you pan across the room, and often try to guess just, what was going on in people's heads, what was going on for people. And, I think for most of us, we're trained to be mostly focused on this person, the patient. And, and if you look at this guy, he looks like he's had quite the night. He's intubated, he's getting dialysis, he's got restraints on, probably a very fidgety fellow. He might have had a cardiac arrest overnight. But, there's a couple people in this room who was always a little bit more difficult for me to guess what was going on in their head. What do you think it was like for them in this scene? What do you think was running through their minds? Because for them, this was not a typical scene. For them, this was perhaps one of the most traumatic moments of their life. So for me, when I was just starting out in my PhD program, I wanted to better understand what was going on in their heads as people, as family members who had to make decisions for patients in this acute care setting. Because folks like these, they make about 1.5 million decisions a year for people who are seriously ill. And that's not without consequence, as about 1 in 3 experience negative mental health outcomes from this role that can last months to years. Now, for my dissertation, I did a qualitative case study using a type of interviewing approach called cognitive task analysis. This was research funded by the AACN and Sigma Theta Tau, where I interviewed over the phone 19 surrogate decision makers of recently bereaved family members after they had made decisions for relatives dying in the ICU. And I asked them to first sort of map out a timeline of when their relative got really sick in the ICU. What were some of the pivotal moments in their experience? And what were they thinking, as they were going through this experience? What was running through their minds? How are they feeling? What were they noticing in this environment? What were they saying? How were they communicating with folks like me and other clinicians in the ICU? And from this research, among some of the things that I found were that surrogates, I think unsurprisingly for many who might work in this environment, they're under extreme duress during this decision-making experience. And much of this duress I found was really attributable to very poor preparation beforehand. They just had never had a conversation or any kind of interaction with the patient where they felt like they knew what they needed to do in this role. And not only that, they just were not prepared for this type of environment, which for any of you who work in the ICU, you know that TV doesn't really capture it. It's much more extreme, can be much more brutal than what popular media images might portray, and thus what many lay folks might understand the ICU to be like. So this got me thinking, seems like preparation for family members probably needs to occur much earlier on. And it also got me thinking, am I just seeing like the tip of the iceberg here for these families? What else are they doing for these patients early on in the patient's serious illness? Like what I am seeing in those images, those aren't like their only experience. They have been going through this maybe for years. So what else are families doing for patients early on in serious illness? Well, they're doing a lot. They're often surveilling, monitoring, and treating symptoms. They're managing medications, and not just oral medications, but also injectables and IV medications. They're delivering breathing treatments, doing fairly sophisticated ostomy, wound, and dressing care, G-tube feedings, and other catheterization. So, things that you probably would see us nurses doing in the clinical environment that we were trained for. So a National Alliance for Caregiving every 5 years or so does a national survey. The most recent one was in 2020. They found that 58% of caregivers are performing these sorts of medical and nursing tasks. And that proportion is actually higher when we look at individuals who are historically marginalized, like African American and Hispanic family caregivers. Even greater proportions of these folks are performing these types of complex care tasks. And yet, 43%, or almost half, are performing these tasks with absolutely no preparation. Now, imagine you're walking around your hospital and 1 out of every 2 nurses that you see, you knew that they had not been trained. I mean, you would flip out, right? Like, you would panic. You would think that, you know, a bunch of these patients' lives are in jeopardy because they have received absolutely no training and they're doing very complex medical care in the home. Of course, you know, it's not just healthcare tasks that caregivers are performing. They also find themselves involved in activities to support a patient's day-to-day living. Here's a lot of them. I'm not going to read off the list. You can read there for yourself. I tried to update some of these percentages with the most recent statistics that you can see cited there below. But what you can see is that, you know, the takeaway from this slide is that these family members are not only delivering complex medical care, they're also providing, almost all of them are providing some other form of substantial day-to-day life support. You know, nearly all of them are performing some support regarding instrumental activities of daily living. You know, a ton are doing medical appointment coordination. They're providing transportation. They're having to take on home and lawn maintenance, grocery shopping, meal preparation, finances. And again, these are activities that prior to a serious illness, they were not doing. So these are additional activities they are now taking on. So remember these folks, right? Like, given everything caregivers do, this image really is just the tip of the iceberg of everything that they may have been doing over the past several months to years. And another thing I realized through work after my dissertation on surrogate decision-making was that their decision-making experiences didn't just start here either. What we found is that families play critical roles in patient decision-making across the entire serious illness trajectory. Here's an example of, in cancer, Gabriella Hobbs and her group found through an examination of national CanCore survey data, which included about 5,300 patients with newly diagnosed lung and colorectal cancer, that half of these family members were sharing equally in these treatment decisions. And that, you know, a quarter, nearly a quarter, or at least some family input. That means that, you know, family, about 3/4, if you add those two percentages together, about 3/4 of family members are highly involved in these decisions along the entire serious illness trajectory. In fact, some work that I did that was qualitative asked the question of what kinds of roles, decision-making roles, are these families playing. They're the ones that are often the ones that are seeking information. They're the informed part of informed decision-making. They're trying to gather information as much as they can. They're often trying to facilitate a shared understanding of the situation between multiple healthcare providers, because typically it's not just that one has cancer. One can have cancer and dementia and diabetes. And so they're having to facilitate communication across all those care teams. They're often the person that has conversations on that front porch with the patient about their values and about what they understand about their illness. These are those side conversations over the dinner table that they're having. They're often the ones that are triggering those conversations and facilitating them. They're a big what if scenario poser. So if you've ever sat down at dinner and you know, you've had conversations that started with what if we got sick from COVID-19, what would we do? What if your illness got really worse? What if I need to cut back at work full time? Those are the kinds of future projections that help people have conversations about future decision making. They're often having to make what I call collateral decisions. So when a patient makes a decision about treatment, say in cancer, there's a whole variety, there's a ripple effect that happens across every aspect of that whole family's life. that causes other decisions to now have to be made. These decisions often for family members have to do with work. Do I need to stop working full time? Do I need to go part-time? If I do that, do I lose my health insurance, which covers the patient? These are very complex decisions, and they're often ones that you don't see in your typical decision aids, but they are part of that ripple effect that happens when you're making serious illness decisions along the way. They're often identifying when decisions need to be made, such as going to the emergency department for urgent care, or when to seek other sorts of help. And obviously, as we kind of showed at the beginning, they're often acting as surrogate decision makers when patients just are decisionally incapacitated and are unable to advocate for their own values and preferences, and now need someone to do that for them. So one thing you might be thinking is, wow, like all that support that they're doing, how much time is that? You know, caregiving is very time consuming. How time consuming? A study in cancer by Robin Yabroff and Youngmi Kim reported data from an 11-state survey of 688 caregivers across 10 different cancer types. And here's what they found. They found that on average, advanced cancer caregivers are delivering about 8 hours of care a day for an average of just over a year. So we're talking a full-time job. If we're looking at advanced cancer, the prior one was just a cancer caregiver. We're looking just at those cancer caregivers who are delivering support to advanced metastatic incurable cancers. They're providing support 11 hours a day for an average of a year and a half. That's 76 hours a week. So how, first of all, can any of you imagine right now, all of a sudden being given a 76-hour per week job with everything that you have going on? It's actually kind of hard to imagine, right? And maybe for some of you, you've actually experienced that. How does 76 hours a week compare though? Like, let's try to get a sense of how this boils down. If we look at a fuel tanker driver, this is one of those jobs that actually requires the most number of hours per week. They're doing about, you know, a little over 50 hours a week. If we look at an oil driller, you know, they can often work close to 60. The 2019 physician average is about 60. If you're a physician out there listening to this, you're like, oh my gosh, I work way more than 60 hours a week. This is an average. And if you look at advanced cancer family caregivers, they're surpassing all of that, right? So they're really putting in more than a full-time job, even more than some of the higher hour paid work that exists in our country. So but the value that these services are worth is also astounding. So again, like that's 76 hours, but it's unpaid. So, you know, those services are inviolable, but how much are we, like, we've had to sort of estimate an amount. It's been estimated that the value of that kind of caregiving is about $71,000 per year. That's actually a pretty conservative estimate, where we would assume that people make about $15 an hour. I'm kind of guessing that some of you probably make more than that an hour, and that if you had to do this, you'd be taking quite the pay cut. Well, and you'd be unpaid anyway. If you had to add all that up with the total number of family caregivers that there are in this country, which National Alliance for Caregiving estimates is about 55 million, somewhere in that range, it'd be about $522 billion a year. I don't have much money. I actually have a hard time understanding how much that is. So let's see if we can wrap our heads around this. The 2018 NIH budget was about 50 billion. So all of the money that goes into research is about 50 billion in total. Apple's 2018-2019 revenue entire was about $250 billion. Sweden's entire gross domestic national product was about 550, and the entire Medicare budget was approaching about 500 billion. So US family caregiving is estimated conservatively in the range of what our Medicare and some countries' gross domestic national product is, which for me is astounding, that this represents a substantial proportion of the economy that we rely on in order to support our population. So you're probably thinking, if you've had personal experience with caregiving yourself, or if you can sort of imagine all the time it takes, caregiving can be a serious threat to one's health. About half probably have some kind of anxiety. About a third have depression. About a quarter experience high financial strain. About a fifth have negative physical health effects from caregiving. And a good proportion has severe pre-loss grief symptoms, which we know predicts post-loss complicated grief and bereavement. And that higher strain has been associated with higher mortality amongst family caregivers. Even more so during COVID-19, all of these numbers have gone up. I don't have the data here on these slides to report, but the CDC has done national surveys as well as others. There's a group in Pittsburgh who's done national surveys of caregiving during COVID-19, and all of these numbers have gone up substantially since we've been living in this era. So one last reason we should all care about family caregivers is because we will be increasingly relying on them to deliver high quality care. Here's a few reasons why. First, the number and proportion of those with serious illness are going to increase. We are getting better at treating very complex, serious illness, which is good. And it means that many of us will be living longer with having to manage a very serious illness on a day-to-day basis. And we're going to actually be relying on others to help us do that. So this kind of naturally follows. There will be an increased time length that folks are going to be living with serious illness, where they're going to probably require some assistance. There's going to be an ever higher complexity of daily home medical management. There's going to be a decreased relative numbers of us. If it's a licensed healthcare profession, it's likely going to go disproportionately and relative to the population in need down in number. That's been true for nursing for a while. It's also true in palliative care, where we simply will not have enough specialist palliative care clinicians to touch all of the patients who could benefit and families who could benefit from those services. There's going to be ever increasing pressure to decrease hospital length of stay and also prevent readmissions. That means that we're going to be relying on family members to take on some of that care after care transitions, and also to prevent readmissions. And then the amount of time that folks lack decisional capacity prior to death is going to increase in number. In all likelihood, before most of us die, we're likely going to need someone to be making treatment decisions for us on our behalf. So, how can palliative care address this urgency of supporting family caregivers? So I'm going to talk a lot about the cancer space here going forward. And in that space, a variety of major national organizations like the National Comprehensive Cancer Center Network, NCCN, the National Academy of Medicine, formerly the IOM or Institute of Medicine, and the American Society of Clinical Oncology, all of these major organizations have really switched their paradigm of thinking around palliative care. It used to be that we delivered disease-modifying treatment up to a certain point, and then we kind of said, you know, we can't cure you anymore. We're going to hand you off to palliative care. That was usually weeks, maybe a month before death. And that's how it used to be. The new paradigm is that palliative care is integrated early on to help with high symptom burden and other coping issues. And that as time goes on, as disease-modifying and curative treatments become less effective at accomplishing the goal of treatment remission or disease remission or cure, that increasing amounts of palliative care becomes the focus of care. And then also the bereavement care is included. And, you know, if you're in palliative care listening to this, our clinical practice guidelines not only highlight that palliative care should be delivered early, but that it should also really focus on not just the patient, but also their family and their caregivers. That we should not only be assessing patients' goals and values, but also the family members who take care of them. What are their goals and values? And how can we best achieve that? And that this early integration should also include the family. So when we've looked at what's been done up to now, when we look at, okay, so we should be supporting family, have we been testing stuff to help them out? The answer is yes. Over the past couple of decades, the number of clinical trials focused on cancer family caregivers, it has exponentially increased. I realize that 2016 and 2020 look a little small there. I just haven't filled it in. I'm waiting on the next big systematic review to help me populate the clinical trial. But you can see the trend here. There's an exponential rise in trials that have focused on cancer family caregivers, including our own. That was specifically a palliative care intervention. So that's where I'm going to go next. So I'm a clinical trialist. I develop and test interventions to support family caregivers of patients with mostly advanced cancer. I've also done advanced heart failure. Where my work started was with an intervention called Project Enable, which stands for Educate, Nurture, Advise Before Life Ends. And my mentor, when I was just starting out, her name is Marie Bacaitis. She is the Associate Dean for Research and professor at the UAB School of Nursing. She had developed Project Enable for patients. And when we had met, I had said, I think caregivers could also benefit from a model like this. And so since that time, she and I have really partnered on offering this sort of parallel intervention care where we've developed a model of early palliative care for patients and for caregivers. So when we look at what is Enable for caregivers, what does that look like? Those caregivers, when a patient is newly diagnosed with advanced cancer, receive a series of charting your course, which is what we call our curriculum sessions, that last anywhere from 30 to 60 minutes. We do this over the phone with folks. And then we do monthly check-in calls and then a bereavement call. So what this represents is a nurse coach forming a very longitudinal relationship with these caregivers, a continuity relationship across settings. So that families have someone that can sort of be along with them for this entire trajectory from beginning to end. So let me just talk a little bit about what these sessions look like. What does this early palliative care for caregivers look like? So our first session really about establishing a relationship. We asked family caregivers to tell us about themselves. We define palliative care. There are a lot of misconceptions out there that it's the same thing as end-of-life care, which it's not. We try to clarify those misconceptions. We talk about and stress the importance of their caregiving role, try to validate what they're doing every day. We deliver some problem-solving education and support, including structured problem solving. This is actually a form of CBT that we've sort of developed a little offshoot of, and this is the counseling approach that we teach our coaches. Our second session is really focused on self-care and symptom management, and not just self-care for the patient and how to be a good partner in helping the patient maintain healthy eating, staying active, staying social, et cetera, but also trying to help the caregiver, also reminding them to take care of themselves. We talk about how to be a good partner in symptom management, including depression and grief. We talk about coping with loss, and not just coping with physical death, but also coping with the loss of the life that they used to have. There's a grief process that happens in serious illness about all those expectations and dreams that one had about how they thought life was going to be, but now how it's not going to be. There's a loss experience there, and we try to help people walk through that. We also address issues around spirituality. In the third session, we talk about communication and decision-making, including how to basic 101 communication skills with clinicians and other family members and the patient. We talk about how families can prepare for provider appointments, how to leverage their social network to help them with their daily tasks. We talk a little bit about medical decision-making, decision aids, and we also begin to introduce some terms around advanced care planning, and we will in fact assist those individuals who are interested in further pursuing completing an advanced directive to do so. So what's the evidence to support this intervention? We conducted what's called a fast-track clinical trial from 2008 to 13 or so, where persons newly diagnosed with advanced cancer and their caregivers were randomized. There was an early and a delayed group. So the early group got enable immediately after signing consent. The delayed group got the intervention 12 weeks later. That's why they call it some of you may know this as a waitlist controlled trial. We call it fast track and palliative care. So folks are randomized to an early and delayed group, and then we follow them until death, and then we complete a bereavement call. So here you can see the timeline. Again, that delayed intervention group is starting at 12 weeks. So here are the main results from that trial. What we found was that early group caregivers, when we looked at 12 weeks, so remember, if you look at 12 weeks, that is just before the delayed group started. So it's basically like comparing intervention versus usual care up to that point. So when we did an analysis looking at that, early group caregivers had lower depressed mood and lower stress burden and trend towards increased quality of life. Interestingly, we also found that when we looked at backwards from death in both groups, there were the same benefits to these early group caregivers when we did what's called a terminal decline analysis, looking backwards in time. So even when the delayed group got a version of early palliative care, delivering it right after this diagnosis with advanced cancer still yielded benefit to those folks who received the program early on. We also did an analysis looking at outcomes after the death of patients, looking at bereavement outcomes. We did not have a large sample to do this analysis. However, we did observe a clinically meaningful effect size benefiting the early group. And while it was not statistically significant, it does raise at least the hypothesis that early palliative care may also be the best type of bereavement care. And doing work now to see if that is in fact the case with trials that we're conducting now. So I did all this work, here. I did all this work up in New England and New Hampshire. I was at Dartmouth at the time. After that, I moved to the Deep South. I moved to the University of Alabama at Birmingham. There we are. And joined the School of Nursing. There's our beautiful fair town. And since relocating to Birmingham in 2013, and even before then, my intervention work has really now focused on underserved groups, specifically African Americans and rural dwellers have been the two historically marginalized groups I have focused on with my work. Here is one trial that we're currently doing now. It's called Project Enable Cornerstone. And instead of nurse coaches, we're using lay navigator coaches to deliver this early telehealth palliative care. Again, in the cancer space. Another intervention trial that we expect to receive funding to start in July from NCI. We'll be doing what's called a Factorial Trial of, again, a lay navigator-led intervention, really focused on training family caregivers to provide optimal decision support to their care recipients with a newly diagnosed advanced cancers. And so that one is more in line with my line of research focused on early preparation for decision making. And then we had just finished this trial about a year ago. We did a randomized trial of nurse coach-led early palliative care for family caregivers of folks with advanced heart failure. We also did that trial in the underserved Deep South and recently published those findings. So just a little flavor of some of the different intervention work that I've been fortunate to do over the past 5-6 years. So one question that, I think a lot about, trying to take all this in, or like, what are the directions for serious illness caregiving research going forward? Like, where do we need to go over the next decade when we're thinking about this type of research? And here's where I think some research priority areas need to be. And a lot of this is informed by these citations that you see here down below. You know, one of the biggest difficulties in caregiving research is actually getting health systems to adopt these types of programs and integrate them into real life clinical care. And I think the reason, one of the barriers to that is that we don't have good data on how cost effective our interventions with caregivers are. And because of that, I think that our intervention testing going forward really needs to examine patient outcomes. It needs to examine healthcare utilization and cost so that we can start to come up with business models that can actually sustain these types of programs and interventions for families. Many families have a variety of different needs, and so interventions that can adapt to some sort of upfront assessment are the types of interventions that I think will ultimately be successful and not just being effective, but also scalable and implementable widely. We need to start identifying the active ingredients of caregiving interventions. There's newer types of clinical trial design called optimization trial designs. I mentioned earlier, some of you may have caught it, what I call the Factorial Trial. There's also SMART trials that some of you may have heard of, or sequential multiple assignment randomized trial. These types of trials really help us understand the mechanisms of these interventions and can better help us refine the active ingredients and components to make them more efficient so that we're using resources appropriately. We really need more testing with underserved minority and at-risk populations. You know, a lot of trials, they will express that some of their limitations have to do with, you know, mostly having a white sample or large proportions thereof. I think that we need to really focus our research to really focus more on health equity and social justice, and need to start testing interventions specifically focused on these historically marginalized groups. We need interventions that last longer, that have a longer duration, and that can be robust across settings. Caregiving is going to be is an experience that lasts a considerable period of time. You saw the numbers earlier that I presented that many are, you know, last longer than a year. If I had talked about dementia, we're talking 5 years and longer for some of those. And so I think that interventions need to really be designed in a way that they're have a continuity to them over time. Technology obviously is exploding every day. And I think interventions, but that said, you know, there's about 1 million apps for caregiving, and the majority of them, if not nearly all of them, are not evidence-based. And so I think that, and apps are just one example of technologies that caregivers can use. We really need to start developing a better evidence base for the inclusion of technology-mediated interventions in our testing. And then finally, interventions that are really tested under real-world settings. You know, when you get a big multi-million-dollar research grant, you can do all kinds of stuff. You can pay people, you can provide a bunch of resources. But until we start testing interventions with folks in real-world settings where you're using existing personnel, it's going to be more difficult to really find those resources when we're actually trying to implement them into real-life practice. So here are some takeaways from the first part of this presentation. First, family caregivers, they're a massive population. They deliver the majority of complex care to individuals with serious illness. They are, in fact, our primary partners in care. They have numerous unmet needs, though, especially training, and they're really at a high risk for distress themselves. Any of you who have been a family caregiver for someone knows that it can be extraordinarily straining. And that palliative care for families can have a positive benefit. However, there are some major needs for future research, particularly around real-world implementation. So now I really wanted to do not a 180, but just pivot here to sort of a different topic here for a second, because I know that a lot of you out there, I think, are in your early stages of your career. Although I think there's a lot of things here that can apply no matter where you are along your career trajectory. And I just wanted to say a few things about what's really helped me in my career development now that I've sort of moved into mid-career stage. Some of those things, here's probably the one I would hype up the most. My success was really due to the fact that I had an outstanding set of mentors throughout my course. I mean, I'm showing a bunch of pictures here. You may or may not know who these folks are. In the middle is Marie Bacaitis. I showed her picture earlier. There was a lot of people, though, involved in helping me get to where I'm at that, I'm deeply grateful and appreciative to. And so what I want to emphasize here is find yourself a team of mentors. The other thing I would say here is that mentorship never ends. It doesn't matter what part of your career that you're at, you will always need mentors. No matter if you're the CNO of a major hospital system, they have mentors. If you're the dean of a nursing school, you have mentors. It's just an important part of the entire journey. I also wanted to highlight that you need a team of mentors who can fulfill a lot of different roles. Some of them serve as your role model. They kind of comport themselves with a standard of excellence and professional behavior that you want to imitate. I think what we often think of, they're like our educator, right? Like they're providing instruction and a content or a methodological area. They can also demonstrate research etiquette and different ways to lead teams. Others are like a counselor. They listen to you, they offer advice to you about career direction and work-life integration, time, energy management. And they help you, they actually give you a little space to self-reflect on what you're going through. Others are your administrative advocates. They actually are the ones that protect you from other commitments and obligations. They can provide you with material and space resources. They can advocate for you to help protect your time and make sure that you're not doing too much and that you're given enough opportunities. They're also like a sports agent or a social agent, right? Like they can introduce you to their entire network of colleagues and leaders in the field that really helps you build connections in your scientific community, and not just locally, but regionally, nationally, internationally. Mentors are often your social gatekeepers, so to speak. They're the ones that can link you with people. They could be your cheerleader, right? Like when you get a big success, like you want someone who is excited about your success, right? Like they help you celebrate accomplishments. I think that's really important. In academia, that doesn't always come around every day. And so when it does, it's really good to have someone in your camp who is really cheering you on. And finally, someone who offers you opportunities, opens doors for you, provides you with special opportunities. They help you say yes and no to different things. I personally think that no mentee or no individual should ever feel like they have to make a major career decision by themselves. It should always be part of a conversation that they're having with their mentors, with their peer mentors, and with others to help really be thoughtful about what you want to say yes and no to. Because, to say yes to something typically means you're saying no to something else. So they can help facilitate those conversations and offer the opportunities for you to help advance your career. I'd say another key factor that has helped me in my career is just a very supportive research community. I mean, palliative care, just the types of folks in that space tend to be, very social and kind and great listeners. And I think when it comes to the research community in palliative care, I wouldn't say anything different. They've been very supportive. They have strong leadership. That I'm showing a couple images here. The Palliative Care Research Cooperative Group has an investigator development center that helps early career folks, both by offering mentorship nationally, but also by offering monthly webinars. The National Palliative Care Research Center, led by Sean Morrison, pictured there, One of my mentors, is a center that has provided grants for early career faculty, and that has offered and supported various conference and research retreat spaces to help folks in their career. And then happy to say that the American Association of Hospice and Palliative Medicine, in partnership with the Hospice and Palliative Nurses Association, is about to sponsor a new State of the Science meeting in Hospice and Palliative Care 1, where one of the primary focuses will be on fostering mentor-mentee relationships and networking. So this is to say that, finding an organization or a group that's national or regional that really supports your research career is one I would strongly encourage folks to start investing some commitment and time to. I've had a lot of thought leadership opportunities that have helped me. And again, this is really due to mentors opening doors for me. I've been fortunate to be on work groups for the National Cancer Institute, also for the NINR, part of their strategic planning work group. And it was, again, an opportunity that was given to me. I'm co-chair of this new State of the Science conference. I also participate nationally as part of the Caregiving Corps, the Palliative Care Research Cooperative Group, where we provide consultation to research teams. I mean, all of these are just opportunities that I've come across that allowed me to actually be a leader to some degree in these different spaces. And so I would tell folks to look for these, to have conversations with your mentors about what might be out there that you could take on and lead. Those have also helped with things like visibility and also promoting your own, I hate to call it brands, but your own program of research and what you're all about. I think it's also been really helpful that people haven't just cared about my research, but they've also cared about seeing it implemented into practice. The UAB Caregiver and Bereavement Support Service was a service that I founded and started at UAB in the Center for Palliative and Supportive Care, where we now provide consultation to departments and service lines here in the health system to integrate caregiving support into their own existing care processes and with their own personnel. I've gotten a lot of support to do this. And so that's been really helpful to really bridge my research to service and practice. And here's what I'll sort of close out on. I think really just sitting down, like with coffee and reflection and maybe conversation, and just think about what your vision is for why you're doing what you're doing. Academia is not easy. Doing research, very hard, pretty stressful lifestyle. I know I'm not saying anything new to many of you. And I think we really have to have good reasons for why we're doing this. Like, why are we killing ourselves to live this kind of lifestyle? And I think one of the things that's most helped me is to really just think deeply and write on paper what my vision is for my research, what its mission is, and what my values are professionally. And how is what I'm doing every day living up to that mission, vision, and values? It's actually a very useful decision aid to get that down on paper. It can help you discern what you say yes and no to. And it also just reminds you why you're doing all this stuff. It's, again, it's not easy. Not everyone can do it. And I think that being grounded with something like this has really helped me stay focused and be able to really know the source of my energy for doing this kind of work. So with that, I just want to say thank you. It's been an honor to be able to speak to you all today on your research day. I hope there's been some helpful things here for you, and really look forward to some conversation. Here is my contact information. Please feel free to reach out and follow me on Twitter. I post about caregiving stuff and academia and stuff. And with that, I'll stop. Thank you.
Thank you, Dr. Dionne Odom, for that wonderful presentation. I think that it was so relevant, and from the questions we've been getting and the comments we've had, I think the audience agrees. We have Are you ready for some live Q&A? Put you on the spot?
Let's do it.
Okay. So the first one is that clearly caregiving for those with a serious illness is different than other forms of unpaid caregiving. For example, providing care for healthy children or aging healthy parents, adults in the community. Could you speculate on whether your work could be translated to these other populations beyond people who are terminally ill, for example?
Absolutely. I mean, there is a lot of, there's a lot of universal characteristics, ways to cope and just simply manage stress that are handy no matter what the context or situation is. And so I think the answer is yes. You know, I have spoken a lot about how my work focuses in the serious illness space, and that is true. But that's not to say that it doesn't borrow, that it's not inspired by, and that it ultimately couldn't be translated into other situations and contexts where one is providing support to someone else.
Great, thank you. So the next one is that, first of all, saying such excellent work and so necessary for improving the work, health, and well-being of family caregivers. You said your next study might be an optimization trial of factorial experiment, testing intervention ingredients for their effects on caregiver outcomes. And can you tell us a bit about which intervention ingredients you will examine and what your optimization criteria or set of criteria are?
Oh, sure. Yay, we get to geek out a little bit on factorial trials. So really quick, a traditional 2-arm RCT, we're testing a package of stuff versus some comparator, right? Like usual care. In a factorial trial, that's not the research question. The research question is, what are the most effective components of a multi-component trial? Results from this trial will allow you to now make the new package, an optimized package of the most effective components. This is like a whole course in clinical trials that I tried to summarize in 2 sentences. So if you're interested in knowing more, please reach out or look elsewhere. So in this trial, the 3 components we'll be testing to enhance family caregivers' decision support skills for patients include 1, communication skills training. So how to be a good listener and how to be a good communicator in the context of providing support to folks making decisions. 2, the second component is training in how to administer decision aids to patients. And we focused on 1, the Ottawa Decision Guide, which is agnostic to disease type or situation. So it's a pretty general decision aid, and where 1 component is trying to see if training and using and administering that decision aid to patients is helpful. And 3rd, we're testing 2 levels of psychoeducation about how to be a good partner in supporting someone in their decision making. It's based off of social support effectiveness theory, and really talks about how to negotiate with patients the different decision making styles that one can come to, where I make all the decisions versus we share them versus you make them and I just give my 5 cents, and other roles that caregivers play. So we're testing sort of a high dose 3-session version versus a 1-dose single session on those types of skills and awareness. So that's kind of a summary of that. When we're expecting to get funding for the fully powered trial in July. We just finished our pilot, hoping to publish results here in the next month or so.
Great, that's great, thank you. So the next question is that you've done such magnificent work on looking at the transition from ICU care to caregivers and their support system. Considering the fact that the COVID-19 pandemic has stressed a lot of the entire healthcare system, specifically in the ICUs and post-ICU care, there are a couple of questions here. 1, how has the COVID-19 pandemic changed or will change the current landscape of end-of-life decision-making in ICU? And then the second one is, how do you see the burden on caregivers being even greater now with the long-term complications resulting from COVID-19 pandemic?
Yeah, I mean, it's almost like where to begin with how this COVID-19 era, as well as all of the other social justice and other, national and international events over this past year. There's so much to unpack and disentangle there. It's hard to really summarize quickly. I mean, as many of you know, and if you've worked in the acute care setting, I mean, families have typically been asked to stay very physically distant from patients who are in intensive care unit settings, often, and it varies from place to place widely, but in general, very strict visitor restrictions. They're not able to be with their loved ones at end of life. There have been a lot of creative and valiant efforts to do things by video and by phone, and to try and help caregivers be present in some type of way. It has been extraordinarily challenging on both the clinician end. It's been challenging on the caregiving end. They're anticipating that complicated grief and bereavement rates are going to be skyrocket for years after this, and it's actually particularly exquisite for individuals of color and other historically marginalized folks whom just feel like it has impacted them in profound ways. We're going to be studying this for years. I mean, you know, it's hard to believe 9/11 was 20 years ago. I am certain we'll be talking about this 20 years from now and still talking about the negative psychological after effects that it's caused. I wanted to quote this in one of the slides, but I feel like I need to have a citation if I'm going to cite data. But the CDC did a survey, it came out in July, I think, or sometime over the summer, where they found that a third of caregivers had seriously contemplated suicide. So I mean, I think that's amazingly striking, and just really shines the spotlight on how severe this time period has been for those caring for someone with serious illness. So what was the second question?
Sorry, actually, we were talking about how do you see the burden on caregivers being even greater, which you just kind of answered.
Okay, yeah.
Good, thank you. I'm gonna switch now. So one question is that the research is very applicable to the physical medicine and rehab setting. And we have in the Twin Cities, the Courage Kenny Rehab has a caregiver training day for their patient caregivers. Do you have knowledge of this research that you're doing being applied to the rehab setting? And do you know anyone who does research in that area?
Yeah, really great question. Caregiving is a very large space. So that it's growing research community. I'm sure there's a big rehab space out there. I have a colleague at Dartmouth, her name is Kathy Lyons, who currently has an R01 to study rehab and breast cancer survivors, and uses problem-solving therapy to help folks combat depression in the rehab setting. So I'm sure there's others. That just happens to be a colleague of mine. So yeah, I mean, I think there's a lot of different tools one could use in that space to help that particular population.
So just digging into the literature a little bit, you probably find some.
Yeah, definitely.
Okay, that's great. So next question, you've provided shocking statistics regarding the enormous amount of time caregivers are providing care, despite the fact that we do indeed know that the statistics are real. I thank you for pulling the data together. In your view, is the burden on untrained caregivers reflected in the quality of US healthcare and outcomes, and possibly an inappropriate shift or premature shift of care to untrained caregivers? Should our healthcare system step in, or should we pay caregivers? And also, in conjunction with that, do other countries notably do better in providing long-term caregiving?
I mean, really great questions. Ultimately, honestly, if we're gonna change caregiving on the ground, we need to change at the policy level, including how we pay for and conceptualize this unpaid but complex care. So I don't consider policy to be my strongest suit. However, what I will say is that it would be impossible for us to pay to substitute professionally licensed care for all of these hours that are being done by these family members. So I don't think that's an option. I do think there's possibility for things like Medicare and Medicaid to offer some support to families and FMLA. has expanded recently to try and include those caring for a seriously ill older, family member in the home. So things are happening. It's a space that's moving fast. I believe that Biden's American Rescue Plan will also have a lot of different supports for family members. And so, all this is to say that I think that the attention is growing. People are recognizing that this is actually a very large part of our economy that would crash if we didn't have it. So I suspect that there will be more creative solutions here, hopefully in the next 10 years.
Great, thank you. Have there been studies done about how teaching long-term care providers basic skills and practices can affect and possibly improve the mental health burden on those caregivers?
Yeah, it's a really good question. I can't think off the top of my head of any specific program, that has, really focused on long-term care providers, really specifically catering to caregivers. One of the challenges that immediately comes to the forefront of my mind when I think about training providers is that ultimately the system is not structured for them to be incentivized to provide direct care to those families. And so I think that kind of work needs to be done, and implementation until our health system changes the way that we incentivize our clinical work, it's going to be really difficult to implement those into practice, albeit I firmly support it, particularly in our undergraduate and graduate education programs. And so I think that's one spot where we can insert, a lot of this education. But I do think that the challenge of providers and clinicians asking them to do one more thing in the clinical environment,
right,
or basically a doubling of their patients, because now, oh, you mean we have to take care of the family member too? That's like double. It's asking a lot for an already strained workforce. So I think we're just going to have to be really creative about how we do this.
Okay, great, thank you. So this is a question that we got ahead of time. Navigating a complex care situation for my parents, I really resonated with your presentation. The data seemed very compelling that family caregivers are essential and yet so undersupported. I'm curious about the cultural associations between palliative care and hospice care in the minds of the public. With my parents, they are very resistant to even looking into the idea of palliative care because for them, they thought it was the same as hospice care and that hospice care means death. They had some stigma and pretty major misunderstandings about hospice and palliative care. Do you see these cultural notions impacting the potential of palliative care to provide support?
Yeah, absolutely. What can I say? Palliative care has had a marketing and image problem from the days when, the death panel talk from Sarah Palin came out. That really made it difficult to present this type of extra layer of support to patients and their families, because they thought what they were hearing when we were offering extra support was, oh, you mean you're telling me that I'm dying? And no, it's not what we're trying to do. And so that way of thinking not only penetrates the public mind, it also penetrates many clinicians' mind. We still have a lot of work to do to restructure the paradigm of what palliative care actually is. And there's actually a couple papers published. I published one on family caregiving, the general public's understanding of what they take palliative care to mean. And it looks like about 50–60% of the public, seems to still sort of equate it with end-of-life care. That changes when they've had any interaction whatsoever with any kind of service like palliative care or hospice. They start to quickly gain an understanding. So I think some of it is just once they've had a touch point, they kind of have a reorientation. Until then, whatever is being portrayed on media and the like is continuing to reinforce the old narrative. So, it's still a lot of work to do. There's a Center to Advance Palliative Care that led by Diane that works on these sort of lobbying efforts to rebrand ourselves. But yeah, it's a challenge. It's a constant reorientation.
So I think, if I'm not mistaken, we're at the top of the hour, and I'm trying to know if we're going till somebody's going to tell me if we have a few more minutes.
10:15.
Okay, we've got 15 more minutes, so I can keep on grilling you. So what do you think needs to be done? So this is sort of tagging on to the previous question. What do you think needs to be done to help family caregivers and the broader public better understand what palliative care can do, other than that touch? I mean, is there more that we can do?
Yeah, I mean, I think this is where we really need to kind of partner with our PR people and honestly people in like media. I mean, this is not an area where I feel at all like an expert, although my sister-in-law's a PR person in New York. I mean, I think that, you know, change in paradigm times of things, like if Kim Kardashian posts something on Instagram, like immediately people buy up whatever it is that is on there immediately. And so all of us work so hard in our careers to like provide data for these kinds of things. And then one, you know, celebrity posts and then like, boom, like everyone's sold. I don't know if that's the solution. It might be part of a creative brainstorming of ways that we need to partner with just other public facing individuals who can sort of be our face, our image, and promote the right, that, you know, the newest paradigm of thinking about the type of care that we provide. So yeah, I mean, there's no sort of single solution in my mind. It really needs to be sort of multi-pronged, and you know, if a movie was made about it, or, you know, for some stuff like that really compels people.
It makes me wonder if perhaps because of the number of people that have been touched by COVID-19 and are recovering, but are still having residual things, that taking this opportunity to frame some of that supportive palliative care in the context of recovery from the pandemic, recovery from COVID-19, we might have a little window of opportunity.
Yeah, I mean, I think that's why stories are important. You know, statistics go so far, stories compel. And I think that as much as we can get individual, compelling, touching stories out there, the more that we're going to really tap into the hearts of people, and then, you know, their minds. So for me, it is a lot about relationship. But I guess I would say that since I'm in palliative care. But
yeah. So here's another personal situation. My mom is a caregiver to my stepfather in a rural part of Montana. She's been trained in hospice work, but that's different from personal caregiving for a spouse. She is stressed out and full of resentment at her situation. What can my siblings and I do to help? We are long distance from her, and what resources would you recommend?
Oh, tough situation. Sorry to hear that. You know, without knowing more details, it's kind of hard without sitting down with you and asking, you know, the whole story, and, you know, who's all involved and what's been the events up till now. It's hard to kind of give really probably concrete advice. You know, I think that many caregivers just simply need to be asked about, and not just asked about because you want to know more about what's going on with the person they're caring for, but they want to know that they're cared about. And just asking, like, how are you? What can we do to help? And if you already know very specific things they could use help with, just go ahead and volunteer yourself for that. As simple as stuff like, do you need me to like come cut your grass once a week? The more specific you can be with the kind of help that you could offer, it seems to be the more likely, you know, families are to take that on if you can volunteer actual. Because, you know, for a lot of family members, they feel like the work they do also burdens others, or like they're supposed to be doing this because if I'm not a good spouse, if I can't do all this stuff on my own, I shouldn't need help. I mean, a lot of those beliefs can impact people's sort of help-seeking behaviors, is how we think about it academically. So I think that, you know, telling her, reaching out regularly, tell her that you care about her, ask her how she's doing, and offer help. And if you know the situation well enough, offer specific types of help would be a couple ways.
Great. Thank you very much. So, so at the end of your presentation stresses that the more real world tests of interventions are needed. Can you talk a bit more about what types of real world tests are in the works?
Oh, sure. So we have I'm a co-investigator on a couple of very large implementation trials where folks are trying to implement one of the versions of Enable for Caregivers at 48 sites across the US and community cancer centers. And what we're doing, like, these are teams that sort of sign up on their own. These are cancer center teams that sign up on their own. It's usually like a nurse coordinator, maybe another social worker or nurse, and they join teams, and we provide coaching about how they can try to implement something like, well, implement Enable, although they often have to make major modifications to it. And we have regular phone calls where we coach them about everything from how to get oncologists on board with this type of care, to how to identify patients, how to reach out, like what should those first contacts be, to actually how to do the sessions. We provide training. So that's sort of an example of one kind of work, is just offering this type of coaching, almost like a CNS role, to other teams across the country. And for this particular study, it's a virtual learning collaborative, which is where you get a bunch of these different groups together on a monthly call, where you offer coaching on sort of like a group basis, and they can offer each other advice. And it's being compared with what's called technical assistance, where they meet one-on-one with someone who's very familiar with Enable, just to kind of get one-on-one advice about how to implement in their own care setting. So that's an example of one of the things that we're trying to do.
That's interesting. That's great. The next question is, what do you recommend nursing faculty do to help share this important work with their students?
I'm sorry, can you say that one again?
What do you recommend nursing faculty do to help share this important work with their students?
I mean, I think that nursing, without like reading the AACN guidelines for undergrad and graduate preparation, I mean, I feel like I was pretty well trained in how to deliver support, I mean, fairly well, to families. It's patient and family-centered care. I mean, I think just faculty who can spotlight that family member is also a part of that patient's life, that they're not just someone who's probably deserving of our care unto themselves, but also because they're our partners in care. Like they're the ones going home and delivering the majority of medical care. So when you think about that patient's transition home after a major whatever, it's probably not the patient who's going to be managing all this. Their family member is going to be the one managing this, and so they really need to be the ones in the room with the patient, being trained and informed and instructed, and as well as also asking them how they're doing with all this. Just asking them how they're doing. What are they doing to take care of themselves is already a lot.
Yeah.
It makes them feel more visible.
Great, thank you. Okay, the next one is, how might this work translate to caring for family members with serious mental illness? Any thoughts on that?
I'm sorry, can you say that one more time?
How might this work translate to caring for family members with serious mental illness?
Yeah, so, in a lot of contexts, like the patients don't have the kind of cognitive capacity. So this is true in sort of the mental health setting. It's true in, dementia caregiving. And so, I mean, I think that those caregivers are particularly challenged with having to now work with a loved one who has major limitations in their IADLs and sometimes their ADLs, where the person can't even communicate well, or they really need almost 24/7 surveillance and monitoring. That's a really intense situation. There are things, I mean, dementia caregiving is a whole space unto itself, and probably the most work in caregiving has been done in that space. So, yeah, I mean, a lot of the stuff of my work, I mean, borrowed from stuff like the Reach 2 intervention, which is a dementia caregiving intervention trial that's pretty well established. So I guess the answer is yes. There are a lot of things that I've done in my work that does translate well to that particular patient population.
Okay, great. Okay, I'm just looking through here to see if there's.
One person made a comment about the death panel debate, and I will say that palliative care was extraordinarily affected by that comment in 2009. We had a major clinical trial in early palliative care, first ever published in JAMA, and that comment by Sarah Palin completely diminished that trial being publicized, which would have completely and really delayed early palliative care in our field a good 5 years before that passed. And we have continued to battle that idea that palliative care is there to ration care. So it had a profound effect in the palliative care space.
Okay, you're looking. So to what extent have translation approaches based on the intervention evidence from your studies occurred? How are we doing it at implementing your science? Is it too early yet, or is it, are we doing it?
Yeah, so, I kind of mentioned the study where we're coaching, those teams at community cancer centers across the country how to implement Enable. I mean, I think, we all have iPhones. There will be an iPhone 10, 11, 12, 13. So we're constantly trying to improve the effectiveness, the efficiency, the cost, the scalability of all of our intervention work. And so, I'm currently just testing the next best thing I can think of that is the next Enable. Right now it's Cornerstone. And, as opposed to nurses, I'm using lay navigator coaches who are actually supervised by nurses because there are so few of us, we need a larger workforce to deliver this care. So, I think as my work goes along, I'll have newer and newer versions that I think are ready for implementation. And so the answer is kind of like yes and no. Like yes, version 11, I think we're trying to get out there. Version 12 and 13, still testing.
Good, okay, great. So this is another COVID era question about family caregivers that the adult children of care recipients are especially struggling. Many are working from home and overseeing children's remote learning. Have you seen this complexity in your work, or do you have thoughts about this?
Yeah, COVID, in the cancer space in particular, has made caregivers hyper vigilant in the very anxiety inducing way of, everything from furiously cleaning everything in their home to just losing sleep over what are they going to do if they catch it? What if I catch it? Does that mean that I killed my loved one? These are the thoughts that we hear running through these caregivers' heads. And so as if they weren't isolated before, they're more reticent to let people like home health come into their homes and say, no, they're taking on everything. They're not taking breaks. So a lot of us have kids at home when we're trying to do work. Some have kids at home and an older adult at home who they're now trying to care for themselves because they don't want to let anyone else into their home. So, it's just, the magnitude of impacts is just, it's so high.
Yeah. Yeah. And will be affecting us for a long time. Okay, this is the last question. We know that caregivers and patients are not ready for end-of-life decision-making when the time comes. Do you think that COVID-19 sort of gave folks opportunity about having conversations on a regular basis about end of life? And do you think that it gives the healthcare workers an opportunity to educate the community?
Yeah, absolutely. There's nothing like mortality that, makes us wake up to needing to plan for the future. And so I think that the rates of advanced care planning, without having like a paper to cite you right here and now, have gone up. And that more and more people are having and more open to these conversations because COVID has struck fear into people's worry about, contracting it and then, really, and with the stories of the families being separated from patients in the hospital, and knowing that they're not going to be right there by their side, like knowing that a conversation is even more important given that context, I think that has gone up. So I do think that for clinicians, this does represent, you know, an opportunity or a conversation way in to have these conversations. So you can just simply start with, so what if your family member gets COVID? Have you discussed? And that line right there, you know, is your entree into a rich conversation that can be had with folks about planning for the future.
Great. Okay, well, we are at the end of our time. I'll look through the questions that I've gotten both in the Q&A and also offline. And if there are more, I will send them to you, and then we'll hopefully be able to provide answers. And before we leave, we're about to go on a break. The posters start at 10:30. And so I invite you to go see one of the many posters that we have in our poster session. And I wanted to let you know that the keynote presentation will be posted on our YouTube channel probably next week. Nick, I just thank you so much. It's been a pleasure. We really wish we could have been in person, as we've said before, but this was the next best thing. And thank you so much for a wonderful presentation. And so I think we're signing off now.
Right. Thank you so much for having me.